It's a great honor and pleasure as a representative of Mykolas Riomeris University to start and to chair this session, which the topic is improving health system productivity, scope for reform as an aspect of sustainable development in healthcare systems. I will chair this session together with Professor Peter Smith. And now I want to introduce Professor. He is co-director of the Center for Health Policy in the Institute of Global Health Innovation, Imperial College London. And topic of the presentation is performance measurement for health system improvement. Professor, the floor is yours.
Sorry about this, but I have no wristwatch, so I have to look at the time on, we have a clock up there. All modern technology. Thank you very much for that kind introduction, and thank you very much to the organisers for inviting me to this very interesting and worthwhile conference. I have a rather daunting topic, which is to talk about productivity improvement, but I want to focus specifically on the role of performance information in securing that improvement. I think our health systems have been, if you like, it's been like trying to fly a plane with no instruments in front of us. And actually we're flying usually through a lot of cloud, and we know there are mountains round about us. And it is extraordinary that we've been trying to run our health systems with such feeble data. And if you look in any other sector of the economy, particularly the service industries, you will see a much bigger investment in information than typically our health systems have done up to now. I want to focus particularly on the role of information in improving efficiency, so I thought I'd better start by just making a few observations about efficiency. And the core thing, everyone really instinctively understands efficiency, is the ratio of valued outputs to costly inputs. And we often think of inefficiency as being what statisticians call a residual. After you've explained why a certain output should be obtained, if that output isn't as good as it should be for the expenditure, then it's that residual which is the inefficiency. It's really important when we discuss efficiency that we make the distinction between efficiency and expenditure control. Expenditure control is easy. You just stop spending. I mean, it's politically very difficult, I understand that. But technically, expenditure control is easy. It's improving efficiency and productivity that is so hard. But when you're trying to assess the efficiency of an institution, of an insurer, of a system, you often need to adjust for the fact that different institutions, different providers, are maybe operating in different circumstances. And so we need to adjust for those. And the sorts of things we might have to adjust for are the fact that in some areas diet might be poor, or smoking might be highly prevalent, or there might simply just be difficult geography which prevents people getting access to care as easily. So we always have to bear that in mind in looking at efficiency. But having said all that, I'm now going to show you a graph, a picture without any adjustment for circumstances. This shows you the link between spending on the horizontal axis and life expectancy on the vertical axis amongst OECD countries some years ago, but the principle is really unchanged. Now, where you want to be on this graph is in the northwest corner. You want to have low spending and high life expectancy. So what economists would typically do is draw some sort of frontier around the best performers in going towards the northwest corner, and say that those that are on the frontier seem to be doing pretty well. Those that are not on the frontier are not doing so well. So, for example, Denmark, I've highlighted there. Denmark is, given that the expenditure that it has, seems to be securing rather poor life expectancy. And certainly if you compared it, let's say, to Korea, which seems to achieve a slightly better life expectancy at half the expenditure. Now, before anyone from Denmark sort of stands up and say, oh, but you've ignored lots of things, I should say I've ignored lots of things on this diagram. And of course, there are many reasons why this might happen. But at the same time, we can refine this sort of analysis and we still find big variations. And without question, for example, the United States is the most egregiously inefficient health system in the developed world. So what's the role of performance information in trying to improve efficiency? Well, we take the view that the prime role is to improve all these different accountability relationships that exist within any health system. So at the center of there we have the government, which is responsible for the stewardship of the health system. But then we have all these other agencies and individuals who are accountable to each other. So, for example, we have the patient. The most fundamental accountability relationship is between the patient and the clinician. But then we also have clinicians being accountable to their provider organization, and so on. And the thesis of the work we've been doing is that each of these relationships needs good information if it is to function well. Patients need good information about the clinicians that they seek care from. Purchaser organizations, insurers or local governments need good information on the providers that they make contracts with, and so on. And only with that information can we get a more efficient health system. So the universal role of performance information in the middle of all that complexity is to enable actors throughout the system to make better decisions. And the belief is that measuring and reporting performance offers one of the most powerful instruments for improvements in effectiveness and efficiency. And up to now, I think it's fair to say that we've really ignored its potential to a large extent. Whose are the decisions that need to improve? Well, I've put governments top of the list, but that's only because they are the most high level. And of course, well, no, I'm sure all governments present would say there are some things they could improve on. And similarly, the government's regulators need information, better information, to improve their judgments on providers, for example. Purchaser organizations I've mentioned already. Provider organizations need the information to reassure themselves and their users that they are providing good quality care and, of course, at reasonable cost. Healthcare professionals, my view is that some of the best health systems in the world are those where healthcare professionals really engage with performance data and share it and benchmark each other. And I think that is, in some systems, that's done very well. In other systems, the potential for that professional improvement is largely ignored. Service users need information to decide whether to undergo treatment and with what provider. And citizens need information so that they can pass judgment on their governments to understand whether those governments are running a good health system. And they also want to be reassured that their local health system is good enough for when they fall sick. So, to illustrate the role of performance information, I'm going to just give 3 examples of its policy use. I fear each of them is drawn from the English experience. England is an unusual health system. It has policy makers, I'm going to be rude about them, but they know that I will be, who seem to have attention deficit disorder. Now that has many bad properties because we are constantly changing our health system at great cost. However, it has some good points, and one of the good points is that we have some interesting experiments to show you, and some of them have endured for quite a few years. So the 3 I'm going to talk about are public reporting of performance, paying for performance, paying providers for performance, and patient-reported outcome measures, all of which are initiatives from the English National Health System. So, public reporting. The stated intention of most public reporting systems is usually to help patients and the broader public. In actual fact, all the research evidence is that people who really take notice of public reporting of performance, and by this I mean of organisations or individual clinicians, the people who take the most interest are usually those same providers. They are interested, even if it's not a market system they're working in, they are concerned about their reputation. Public reporting can be highly effective, it's been shown, and I'll show you an example of that, but you do have to be terribly careful with it. If you report the wrong things in your public reporting, it will hardly be surprising if the providers concentrate on those things you're reporting, and they may ignore important things you're not reporting. And also you can have unintended side effects, and for example we've had terrible stories in the UK of fraud and manipulation of data. So these are the sorts of things we see across Europe. These are rather old examples of public reporting where providers are ranked and reported. I think no one would really believe the rankings very strongly, but it does at least capture public attention, and of course it captures the attention of the providers as well. That's our usual fair and balanced UK press for you. I want to give you just one example. We've had in the UK, in England, we had terrible waiting times, and this is the number of people by the length of wait. So the red people have been waiting 0 to 3 months, orange 4 to 6 months, and so on. And you'll see that in 1997 we had 1.3 million people waiting, and some of them have been waiting more than 18 months this is for routine inpatient care. So in the year 2000, the government gave a big injection of new money into the system, but it was conditional on achieving better waiting times. And the way that the ministry did this was to create public reports which were heavily based on waiting times of individual providers. And they set some really serious incentives alongside that. So chief executives were told, of the worst performers, were told they would lose their jobs within 12 weeks if they didn't improve. And you'll see that system was sustained, and by 2010 we have very, very few people waiting longer than 3 months. Now that was a policy success up to a point, but, and we can judge that by comparing England against Scotland. These are the red and the blue here. It shows that England improved much better than Scotland over the same period. Scotland didn't have these targets. Scotland had instead a system which had very little impact, and the reason we think for this bit was that their data had poor credibility, relevance and timeliness. There was a lack of awareness and expertise on the part of clinical staff to understand the data, and there's a lack of incentives on the Scottish hospitals to scrutinise and to do something. And the incentives do matter in this area. But there have been some serious adverse side effects of relying too heavily on public reporting and targets. And so, for example, here are a couple of stories on our front pages. And we've had an even worse example recently, where an entire hospital really became completely dysfunctional because it was pursuing the targets in the public reports at the expense of compassion and clinical quality. My argument would be that that doesn't discredit the use of public reporting, but it means that maybe public reporting should report the things that really matter, the patient experience as a whole, rather than just focusing on one aspect. My second example, I'm going to have to go through these rather quickly. I see I'm running out of time. But the second example of use of performance information is in paying for performance. It is amazing that our health systems, until recently, have paid providers without any conditions on the level of performance that they achieve, on the quality and so on. So this is an attempt to align the payment of providers with their performance. There have been experiments in many countries. You can either reward processes of care, are you sticking to guidelines, or you can reward the outcomes, are you getting good patient outcomes. The results so far, has to be said, have been modest, but I think we're beginning to see improvement in the focus of these schemes. We've done a study in conjunction with the OECD and the European Observatory looking at schemes, and that there will be a book coming out pretty soon on this. And here are some examples that we cover in that book. France, Germany, Australia, UK. Also been a lot of examples in low-income settings as well. The example I just briefly wanted to show you was the UK Quality and Outcomes Framework, which is aimed at general practitioners. About 20% of their income is based on their performance measures. 150 performance measures are collected from every general practice. 20% of their income depends on their performance. This is the hypertension area. The two I'm going to focus on are at the bottom there. So the measure is the percent of patients with hypertension where there's a record of blood pressure in the last 9 months. You get up to 20 points for that. And then the fifth one, the percent of patients with hypertension in whom the last blood pressure is 150 over 90 or less. And you get 56 points if you do well on that. So those are the sorts of indicators, and the more points you get, the more money you get. These are the trends. The scheme was introduced in April 2004. You can see there's a slight, that things were improving already, but the scheme has definitely sustained that improvement, although not everything can be ascribed to the pay for performance scheme. When we looked across Europe, the OECD, this will appear in the book, but it's just a table of the OECD countries showing the areas in which they have pay for performance. Left-hand side is primary care, lots of primary care schemes, some for specialists, and relatively few in the hospital sector. So, there's a lot of work still to be done here, but I think that there's already quite a bit of interesting experience across OECD countries. Finally, just a few words, if I may, Chair, on patient-reported outcome measures. We're pretty poor at measuring what happens to patients after they leave hospital. Some of our systems do measure death. Death is pretty easy to measure, but fortunately it's also rather rare, and it's not a good outcome measure for most interventions. So can we improve on that? Well, the experiment in the UK has been on patient-reported outcome measures. Actually, this movement started measuring outcomes in 1861, when Florence Nightingale reported risk-adjusted mortality rates for London hospitals. But things really didn't change much in the following 150 years. We still relied on mortality as an outcome. This really matters because we get headlines like this regularly in our newspapers about disparity in NHS death rates, but actually the methodology for creating those hospital-based standardized mortality rates are highly contested and really quite problematic. So that's the reasoning for going for patient-reported outcomes. We also, just one more word on mortality as an outcome measure. Also recently, the England instituted reports on surgeon-based mortality rates for about 15 surgical procedures. And this is the difficulty that arises. We get headlines like this. So surgeons, so a misunderstanding about risk adjustment and uncertainty. The fact, again, that the numbers are too small to spot poor surgeons. Again, same sort of issue there. And then the outcome was there was a lot of confusion. So, can we improve on it? Well, what we've been trying to do is to apply this EQ5D patient-reported outcome. This is a very simple instrument with 5 questions for patients to answer about their mobility, self-care, usual activities, pain or anxiety. They are asked this before and after, about 6 months after their intervention, and it's an independent collection of the data. So far, it's only been applied to 4 procedures, which is hip replacement, knee replacement, hernia repair, and varicose veins. These are some very early results. Unfortunately, the later ones haven't been publicly available. So if I can just dwell on this for a second, this gives you the pre-operative and post-operative score on that instrument for patients in each of the 4 areas. So this one here is groin hernia repair. And I would like you to focus just on the X there. That shows you the average level of that score, self-assessed health, on the EQ5D before and after treatment. And you'll see that the increase is pretty modest for hernia, and there's a lot of uncertainty around it as well. In fact, one of the general practitioners in York, where I live, has been showing his patients this result before they go to the hospital for a specialist appointment, and he has found that only one person, since seeing this data, only one person has decided to go for a hernia repair because they hadn't realized how modest the improvement in self-reported health was. In contrast, the hip replacement, some pretty major improvements in health from that. Knee replacement, similar, slightly less. And then also varicose veins, rather modest improvements in self-assessed health. Now it may be that our instrument is rather weak, but this is much more sensitive than, for example, any index of mortality, which of course is virtually meaningless for these treatments. So, there are I'm out of time, I see, so I'm really just going to have to briefly say everyone can find reasons for dismissing performance information. And these are the sorts of excuses we hear. You cannot measure what we are trying to achieve. That's especially prevalent in the mental health area. Our objectives go beyond what you are trying to measure. The data you are using of poor quality cannot be relied on. There are external factors that influence our performance that you have not taken account of. The risk adjustment methods you have used are inadequate. There's huge uncertainty in these reported measures. The data are out of date. And when the providers have finally said, okay, all right, you've tried your best on all these things, but anyway, we're still unique and cannot be compared with other institutions. And those are the stories that you get. So the analytic task is to answer each of these objections, because these are legitimate complaints or concerns. And I think it's very important that analysts make sure they try and address these concerns. Okay, so just in conclusion, just to say, without performance measurement, we've got no means of identifying good and bad delivery practice. We've got no evidence with which to design health system reforms. We've got no means of identifying good and bad practitioners. There's no protection for patients or payers. And ultimately, there's no case for investing in health. I think our finance ministries and our citizens are increasingly going to ask us to justify the huge expenditure made on healthcare. And so I think we've got to get this performance measurement right, and it will help us improve the productivity of our health system beyond measure. So thank you very much for your attention.